So welcome to Afrometrics research-based news. We're joined today by Dr. Colleen Campbell. Professor Campbell has a unique and impressive unfolding career. She is an acting assistant professor of lawyering at NYU School of Law. Her research employs intersectionality, critical race theory, critical constructivist lenses to examine the ways in which the law and medicine institute systems of racial hierarchy and domination. Her current projects examine stratified reproduction, reproductive justice, disparities in obstetric and gynecological procedures, and informed consent in reproductive care. Prior to returning to the academy, she worked as a labor and public interest attorney representing unions and workers. She holds a JD from the University of California, Hastings College of the Law, and PhD in sociology and African American studies from Princeton University. She is someone who is uniquely qualified to offer Black communities insight into law, medicine, and race. So Dr. Campbell was invited for a discussion today about a paper of hers that was recently published in the Michigan Journal of Race and the Law. And that article was Medical Violence, Obstetric Racism, and the Limits of Informed Consent for Black Women. Dr. Campbell, thank you for accepting my invitation and welcome to Afrometrics Research-Based News Show. How are you today?
Thank you for having me. I'm doing great. And thanks for such a kind introduction, Dr. McDougall. It's a pleasure to be here. Thank you for reaching out about my article.
No problem. Thank you for accepting. And where are you from?
So,
yes.
I was born in Jamaica and came to the United States when I was 11. So I've been in the United States longer than I was in Jamaica. So I consider myself a hybrid, a Jamaican, if you will, by way of New York City, where I was raised in, predominantly immigrant Black communities. And so much of my research is US focused, although I do have and think about some of the issues affecting Black immigrants as well.
Do you think that informs your interest? Does that inform your interest in medicine in any way?
Do you mean my immigrant background or?
Yeah, your background, Jamaican background.
Right.
And
so
your approach. Mm-hmm.
So in terms of my interest in medicine, that came out of really personal experiences navigating the medical system as a Black woman. And so even before I went back to do my PhD at Princeton in sociology, I had started to think about how racism affects health. And so at 30 years old, in 2014, I found myself having to have a reproductive surgery. And that was the seminal experience that got me started thinking about how it is that Black women are more likely to be exposed to certain types of surgical procedures and what it means for Black women's reproduction. And so, I started, just talking to the Black women in my community, and just any Black woman that I could, that would share with me about their own journey, and I started realizing that there are a lot of common experiences. In terms of being of Jamaican heritage, I think that growing up in New York City, the communities are, for the most part, integrated in the sense of, and I mean in terms of immigrant Black versus American Blacks, right? Not racially, because New York City is very segregated, and that contributes to a lot of the health disparities that Black people experience. And so I think that growing up in New York City, in the among Black people from all backgrounds, either Caribbean or African, and having these common experiences of healthcare, that certainly informed my research agenda. So yeah, that's my background definitely is a critical aspect of what motivated me to do this work.
Wow. And I would hate to detract us from the main article, but I was looking into some of the other work that you've done, and what you just mentioned, it kind of made me think of something from one of your other articles, the one you did on COVID-19, and where you were talking about how Black people's concerns or their skepticism when it comes to medical care has a lot of times in the media has been reduced to, oh, well, Black people are still concerned about the Tuskegee experiment. But I mean, clearly, I mean, what you mentioned was your own contemporary experience, and you talked to other Black women about contemporary experiences with racism, with sexism, dehumanization. You even used the language of dehumanization in your article in Medicine. Do you want to expand on that? How Black people's concerns in medical care have been reduced to historic uh, forms of discrimination?
Sure. I think that like you said, especially recently when the conversations started emerging about recruiting Black people to participate in clinical trials, a lot of it centered around medical distrust, and much of it also is that this is part of this rhetorical strategy to say that not only is Tuskegee something of the past, but also it's an irrational fear that Black Americans have of being exploited. And what my research does, both in my dissertation research, it really shows that exploitation is not something that happened in the past for medical exploitation. It's ongoing, and as long as medical racism or racism exists, medicine will be a site for playing out all of these inequalities. And what we've seen, especially in the pandemic, is how health disparities were exacerbated by the pandemic. And that has everything to do with a system of medical neglect in America. And so, how Black people are treated today by medical providers in the healthcare system. That has nothing to do with a fear of experimental therapies connected to Tuskegee, but just ongoing devaluation. And so how you are perceived when you go to hospitals. I, for example, was given a drug test. I went into the hospital for complaining about a number of issues, and when I leave the hospital, I go home and I see a list of a panel of drug tests that were conducted on me without my consent or awareness. And that is very frequently done to Black people. And that is because of, first, the criminalization of Black people and this presumption that you're always seeking after drugs. And that plays out in medicine as well. So I think that there is a rightful skepticism of being devalued in medicine by medical actors, and it's rooted in a long history of devaluation. And I think that this is a critical aspect that's often missing in some of those conversations.
Yes, and one of the things I wanted to speak to was, I mean, for people who you just heard Dr. Campbell's bio, it's a very unique combination of skills, of expertise. And so I wanted to ask you, given this background you have the background as a lawyer, law school, representing union workers, PhD in sociology, but then also African American studies, and then a research interest in medicine. what would you say shapes what is your overall theoretical approach, your overall conceptual approach to medicine and law?
So I study primarily, right, how, um, for the most part, right, how Black women experience and navigate, right, medicine. And I examine in my dissertation, I look at, right, obstetrics specifically. My lens is predominantly critical race, reproductive justice, and intersectionality. So it's multidisciplinary, but it's basically a critical examination of both law and medicine. And in terms of reproductive justice, right, the idea is that every person is entitled to the legal right to make their reproductive decisions free from coercion by any, right, external entity, including the state. And it came out of the reproductive rights movement, which was centered around abortion rights discourse. And so reproductive justice today, we know, is an important aspect of advocating for Black women's reproductive right agency. So it encompasses not only the right to have or not to have a child, but to have a healthy birth, for example, right? To have to give the right to give birth to a healthy child and to raise them. And so it intersects with some of the issues or critical issues around the child welfare system that has disproportionately affected Black women, Black families, right? It intersects with birth justice, right? The right to be able to choose how you give birth, right? And when and where to give birth. So my lens is multidisciplinary, and certainly it's critical race in the sense of, right, it looks at the law's impact on the lives of Black people and Black women. And how can we, right, use the law to affirm and to support and to protect Black women from, right, medical neglect or medical violence. And so I think that because of my diverse experiences, I always bring to my research a critical lens that looks at race, gender, and class primarily. And yeah, I think that having gone through these different disciplinary journeys, so to speak, has made me have a very well-rounded understanding of law and medicine.
Yes, and I think it comes through in the article that you wrote on medical violence, because you of course you draw on Harriet Washington, who wrote the book Medical Apartheid, but then you also add a approach that looks at some things that I think the average scholar would miss, that are kind of specific to the medical practice and the influence of law on and the subjectivities of doctors in some cases. So there's a very unique approach that I think you have. And when you were giving you were talking about the unique experience that you had with medically, it reminded me of how you opened your article. You talked about this high profile incident that took place with Serena Williams and her exercising her voice as a patient, as a Black woman, and how that I thought that was a great way to open up your article. Can you talk about that experience that Serena Williams has and how it relates to medical violence?
Right. So I chose Serena Williams' experience because it's a powerful one, right? Here you have a prominent, well-known person who's right considerably well resourced, and she is right in all respects a powerful woman, and yet she finds herself right in a very vulnerable space, right? And so I use that to talk about what it means for right obstetrics to be a site of power differentiation. And so when you're given birth as a woman, you're right, there is a clear power hierarchy. And so you are being forced to make a lot of decisions when you are in your most vulnerable state and you're in excruciating pain. And for a lot of Black women, it means needing to be an advocate and a patient at the same time. And that becomes untenable, right? And so what happens often is, right, if you, the average Black woman given birth, in that situation, I have no reason to believe that, right, the outcome wouldn't have been different. And by what I mean is, right, Serena Williams had to self-diagnose, right, and had to insist that this is what was happening to her. You know, if she had not, right, insisted repeatedly and made sure that they gave her the CAT scan and the treatment that she needed, then, right, she would have been among the statistics that we know of, right? And we know that Black women are 3 to 4 times more likely to die in childbirth, right? And we have these raw numbers, but we don't know what's going on in the labor and delivery room. And we have this great example of, here you have somebody who has an underlying condition, a health condition, and she's predisposed to pulmonary embolisms, right? And so she definitely has a risk factor for an adverse health outcome. But that by itself is not a recipe for death or, all of the more extreme situations that we hear of, right? What it means is that a physician needs to listen to her, right? Listen to the patient, right? And respect and honor the patient's, right, what the patient is saying. And on average, that right, a lot of women get dismissed. Their voice is silenced. If you're a Black woman, you are, right, treated with disrespect, and you're treated as non-compliant, right? Another woman in Serena's case would be treated as a non-compliant patient who doesn't want to listen to the provider. And I think that, this case shows how the power hierarchies play out in the medical system and how it can expose Black women to really adverse health outcomes. And it's not necessarily because of these underlying risk factors, which exist, but it's because of some of the institutional practices and how how providers treat Black women, right? How they dismiss them and ignore their complaints about pain. And so I think that that's a great example of even the best case scenario for a well-resourced, wealthy Black woman is still very vulnerable in medicine because of racism and because of medical neglect.
What would you say is the relationship between how Serena Williams was treated and the unique history of Black women's treatment in the medical establishment in this country?
Sure. I think that you can't have a conversation about contemporary medical practice, American medicine, without, right, its racist roots, right? And America, right? And I think it's right. In my paper, I talk about the symbiotic relationship between slavery and early American medicine, and what it means that the two, right, institutions, slavery and medicine, evolved, right, symbiotically and fed each other. And so medicine, right, then needed a lot of practice materials, and that's where Black bodies become very instrumental and become expendable for medical progress. And I talk about the woman that J. Marion Sims experimented on. And I think that that's an important aspect of, contemporary understanding where we are, because we're still facing the ripple effects of slavery, post-slavery medical exploitation. And so, the 20th century, I think that we're still on the historical continuum of, right, medical exploitation. And it looks different in some ways, right? But it's still the same fundamentally in terms of the outcome. And so why do we have, Black women dying so much more in childbirth, but for the fact that Black bodies are still devalued in medicine? And so, right, that's the most important, I think, point that I want to highlight, right, is the devaluation of Black bodies that subjects them to a lot of reproductive harm, right, the devaluation of their reproduction as well. The fact that J. Marion Sims felt comfortable to just butcher these women essentially, and not in, right, and some of them don't even receive the therapy, the reparative therapies that that came out of these experimental surgeries. And so I think that even, it might look differently, but the effect or the process of devaluation continues. And we saw even more recently, a lot of cases with sterilization, non-consensual sterilization in these in this immigration camp, I think last year. And a lot of the women were Black and Latino women who were being given non-consensual reproductive procedures. And, I think that is emblematic of how it is that Black women's reproduction is, right, continually treated as dispensable, expendable, and disregarded.
One thing you also discuss is informed consent. And informed consent is supposed to protect participants in research, also in medicine. But you explain how power differences and racism, they have the ability to, I think you said, reduce informed consent to a legal fiction for Black women. Can you talk about informed consent and how it can be reduced to legal fiction for Black women?
Sure. So I think that for me, right, I think as a critical race scholar, I think it's important to, right, to identify these principles, these legal and bioethical principles, right? The right to autonomy, bodily integrity, right, and respect, and the right to make choices without, right, coercion, right? Those are really lofty goals, and they're idealized by the law. And yet, I think in everyday interaction between providers and patients, especially in obstetrics, which is what I study, informed consent as it materializes, right, depends on a lot of factors. And so what happens really is, right, access to information, to social resources, right? So those who are able to have the best birth outcomes, for example, those who are able to access a birth doula who is able to support them, through their birth, right? That takes resources, usually white women. Those who are able to, go to a freestanding birth clinic or to have birth center, or to have access to a midwife, or to just being able to access all of the resources, that are necessary for to be able to have, right, your choice of birth, right? That depends on your social status, your socioeconomic resources. And so, what does it mean for, right, freedom of choice, right? So, aside from the fact that women are routinely coerced and pressured, and I see it in my own research, right? I see how birthing can be the site of really contestation and a lot of, right, conflict, because physicians are pressuring women to have certain interventions. But also, right, if you don't have access to a doula and you're a Black woman, young Black woman without resource, you're probably just going to succumb to a physician recommendation. And so, right, the point that I want to emphasize is how, right, these idealized principles don't materialize in the medical setting the way that they should. And in fact, for Black women, they're less likely to. If we think about the coerced sterilizations that happened over 50 years ago, where, I talk about the Ralph sisters, and women being told by providers that they need to get sterilized if they want to continue receiving treatment, or if they're on Medicaid or public assistance, they're being threatened, that those services are going to be terminated if they don't get sterilized. So, all of these population control policies that have been directed towards Black women by the state and carried out by providers who act as agents of the state, right? I think that the idea of, right, informed consent doesn't really begin to grapple with some of the systemic violence or violations that Black women receive in medicine. And so that's that's my critical analysis of informed consent.
And in addition to what you just said, you also mentioned how, like, if you're going to make an informed decision, you have to have information from the person who is the expert.
Right.
But you also mentioned how law can be used to limit how much information gets shared from a doctor, for example. How does that work?
Right. So the requirements of informed consent is that the patient has, right, all of the information that they need to, right, make the most optimal or the best treatment outcome for them. And so the law, right, mandates that, right, the patient has the knowledge of the risks, the benefits, right, and the alternative options to whatever treatment course that's available. However, a provider can, if they want to steer you towards a C-section, they can, easily steer you towards it by talking about the risks of, right, of a natural birth, without equally emphasizing the risk associated with, right, a C-section. And that partly, right, that is part of the reason why there's so much such high rates of C-sections in the United States. As well, the fact that a lot of these recommendations are informed by fear of liability by a provider. So the fact that, right, these are non, right, medical factors that are informing a treatment recommendation, but a patient may not know that, right, part of it is because of risk aversion by the legal risk aversion, not medical, but legal risk aversion. And so the patient gets recommended a course of treatment that's not necessarily medically the best for her, but it is either convenient for the provider or it's part of, I talk about the defensive practice of medicine. Yes. And
that's interesting.
Some people describe that as when doctors practice medicine as lawyers instead. And it's a real issue that's not discussed as much. And we see, like hospitals have this, like a majority of hospitals in the United States, right, ban vaginal births after a C-section. And so there's a saying, once a C-section, always a C-section. And so even regardless of your own individual, right, circumstances as a patient, right, you will have a hard time getting a doctor to give you a natural birth or vaginal birth after cesarean. And that has a lot, that's not evidence-based because of the studies that show that there are equal risk or there's actually more risk associated with cesareans, even a secondary cesareans, compared to a vaginal birth after a C-section. But that's connected to, right, fear of liability. And so if you're a doctor and you've given a patient a C-section, you're less and there's an adverse health outcome, you're less likely to be sued, or you're covering yourself, so to speak, because the C-section is the way to manage risk, and that's the procedure that's used to manage risk. And so a lot of providers may choose that route because of legal reasons and not necessarily for medical reasons.
You addressed another thing that I wanted to ask was about that defensive practice of medicine. But why is the C-section something that limits the risk for the doctor?
Legally, it's a matter of what the law considers, right? So if you have a vaginal birth and something goes wrong, then in the eyes of the court, then that's going to, you're going to be looked at as if you didn't do everything to manage risk. And so it's considered legally to be a risk managed technique, even though it has its own health adverse negative risk outcomes. But it has everything to do with the state of the law in terms of what a provider is expected to do in terms of managing risk. But it factors into medical treatment recommendations because a patient may not need to have a cesarean section, and in fact, certainly cesarean sections are necessary sometimes. And there's an actual statistic that, let me just give a background, the World Health, I think I talked about it. So the World Health Organization says that it should be around 15%. In the United States, it hovers around 30% or even more. In some hospitals in the United States, especially in poor Black communities, it can be 40%, right? And so what that means is you have a lot of healthy, young Black women who are getting a major surgery that exposes them to a whole lot of other postpartum health risk, infection, hemorrhaging, and all sort of complications. And so there's a lot of people who are getting C-sections that don't need them. And that has a lot to do with hospital practices and policies, the malpractice and environment, right? I think that, sometimes the pushback is that these are elective surgeries and these are, just women's choice. But when the studies that come out, they're showing that, for one thing, it's not because women have gotten healthier over the year why the C-section rate has increased so much, and it's increased steadily in the past decades, and it has nothing to do with elective C-sections. And so it has everything to do with what's going on institutionally, and Black women bear the greatest brunt of all of this because their bodies are having more of these medically unnecessary surgeries. So I'll
and so there are those who say that the disproportionality of Black women who have these surgeries is due to factors such as socioeconomic status, age, pre-existing conditions, and your response to that?
Right. So, this idea of high-risk populations, and I remember when the pandemic started, and a lot of it was disproportionately hitting the Black community. And I remember a health administrator at one point said, okay, this was because of the comorbidities of Black people. That's why the pandemic was disproportionately hitting the Black community, and Black people are dying so much. But we know that really what was happening was, all of these social and economic reasons, right? So who is able to be a, stay-at-home worker versus who's an essential worker disproportionately falls on the poor and Black, and a lot of Black women, right? So who has to go to the store to work, who has to leave, who has to travel on public transportation, right? Disproportionately poor and Black. And so all of these are social conditions that disproportionately expose Black people to health outcomes. And, you know, I do think, right, there is certainly a rich body of, right, analysis in, right, the social determinants of health, right, framework, right, which looks at how racism becomes embodied, right? So, right, all of these stress outcomes, right, that are connected to racism, right, higher rates of all of these comorbidities, they're certainly there, and they are socially produced, right? Whether you were talking about ecological factors, right, where Black people live in this country are more likely to live, what they're able to have access to, and the psychosocial stressors that come from, right, being either poor or marginalized or constantly an object of racial violence, police violence, and state violence, and those are reflected in our bodies, right? So we embody all of these environmental and social, right, conditions, right? But what I'm saying is that the studies that I look at, right, in terms of, right, the over medicalization of Black women, right, you're having, right, even when these studies, they control for all of these health outcomes, right? So you're you know, one of them I highlight, the researchers control for everything, about 20 or so risk factors for a cesarean section. Yeah. And even after doing all of that, Black women were still more likely to have medically unnecessary cesarean sections, right? And even, right, I think my critique of how, right, these issues are discussed is that either they still look for something in Black women's bodies, right? There may be something that we're not accounting for in Black women's bodies that are causing them to have higher rates of C-sections, right? And that for me is a way to obscure, right, physician racism in all of this. Institutional practices that I just discussed in terms of, right, you know, over medicalization. And so, you know, I think that, right, for me, the most important in my paper, the most important thing that I want to talk about is, right, those young, healthy Black women who, in my study, for example, right, even beyond, right, those women who have to fight to have their natural birth with a provider, right? Or a doctor who just wants to have their weekend and not want to labor with you and treat you as an inconvenience and just want to chop you up or cut you open just because they want to, like, be done with you, right? There are a lot of, like, hospital policies, right? Where some women don't even know that they're being steered in a particular direction, right? And this tends to be in poor communities where a hospital can, right, have these informal policies. And I can talk about examples, but the point is that, right, there are a lot of people who are having major surgeries, like, you know, in birth that don't need them. And I think that we need to talk about those examples. So even if every Black person, every Black woman got their blood pressure in check, got their diabetes under control, got their, you know, everything physically robust, right? A lot, they would still have greater rates of these interventions than, right, a comparable white person. And I think, I think that that's what's missed. And that has everything to do with racism, medical racism, and which intersects with gender and obstetrics violence.
I want to ask you about this. There's in what you refer to, and I'm paraphrasing, so please correct me if I'm wrong.
Sure.
That the medical establishment has kind of promoted a mainstream notion of what a patient is supposed to behave like. Mm-hmm. And I would imagine that you talked about Serena Williams and the kind of agency that she had to mm-hmm. exhibit violates that mainstream notion of a of what a patient is supposed to behave like. Can you talk about what that notion of what a patient is supposed to behave like, and how the impact that it can have on Black women, Black women's health?
Sure. So I think that there are a couple of issues there. And so this idea of a docile patient or passive patient, for example, is a good patient, right? So the one, right, you're not supposed to be asking too many questions or challenging providers. And it has everything to do with this notion of physician paternalism, where the physician is the physician possesses, right, this monopoly on expertise, right? So they have all of the knowledge and skill and the expertise that's needed, and you're supposed to be deferential to the provider. And so that, that's definitely ingrained deeply within medicine. And of course, the physician is expected to do what's best in the best interest of the patient. And, ideally, if that were always the case, then it wouldn't be as, right, there wouldn't be as many problems there. But, what I discussed about the way that obstetrics is practiced, and all of these non-medical factors that are influencing physician recommendations and treatments that have nothing to do with the patient's best interest, right? And even the fact of, right, biological race, which causes, patients to be racially profiled, right? And then just all of the issues of like medical or physician racism that goes there, that distort medical practice. And so for Black people, Black women, right, I think it is in your best interest to challenge and to question, right, medical authority, right, and not assume that, right, every recommendation is going to be in your best interest, because it is not, right. But those women who do complain or challenge physical authority, they're dismissed by providers easily, and or silenced, right. And so, right, what we see with Serena Williams is that, right, at first she's told that you're just responding to your pain medicine, right? You're not really having what you're thinking you're having, right? And so you see her coming up against this, right, wall of dismissal, right? And so she has to be hitting against that wall repeatedly to be heard and to have the treatment that she needs. And unfortunately, though, a lot of women, right, especially women, because there's this gender idea too that, right, that affects, right, our socialization of women. And a lot of women want to be the good patient. We don't want to be, right, bothering or upsetting your physician, right? And a lot of it that is fear that your physician is just going to say, okay, go somewhere else. And that does happen. I've seen that, right? Physicians trying to dismiss women while they're giving birth, trying to send them to another hospital or just discontinue treatment because they, right, don't agree with the patient. And so I think that Black women, especially if they diverge or depart from the ideal, good patient, they can easily become, right, marginalized or described as non-compliant. And that, intersects with a lot of, right, these long-standing notions about Black women as being difficult, right? When, right, there is a lot of reason not to trust the way that medicine is practiced because we're constantly being devalued.
What you just mentioned, I was going to mention that there's the docile expectation. Then at the same time, it would seem to me, you mentioned the domination and stereotypes, that there would also be the risk of being dismissed as an angry Black woman. Mm-hmm. On the other hand, right, in addition to in a space that's defined by this expert, this intellectual, this expertise, you have the anti-intellectual stereotype about Black people in general. In addition to the stereotypes about Black women, it would seem that those things would those could potentially intensify this hesitance in that particular scenario. So yeah, you make the argument that this goes beyond prejudice. You know, this goes beyond even the language of racism.
Yeah.
You use the language of violence and dehumanization. And why do you choose that language? Why do you make that distinction that this is prejudice and racism are not enough to capture what's happening here?
Right. I think that, so I'm right. So I'm gonna be a humble Black woman and say, right.
Wait, wait, we don't
Psychoanalysis
have
is
to do
not
that.
no, but you know what? So I'm talking about the psychoanalytical field, which I don't study, right? Not right. I don't have a PhD in psychology, and this is what psychologists have been doing. These studies, and they're showing how dehumanization operates. And so for me, it's kind of this experimental lens that I'm playing with and hoping to add some complexity, because I think that just this idea of animus or even unconscious bias, doesn't really paint the full picture of some of the experiences that we've seen, right? If you talk about the Tuskegee, right, a lot of the researchers were going in over decades, day in and day out, seeing these patients deteriorate because of the infection that they got, and we're not treating them. A lot of them they were just treated as basically lab rats. And so it wasn't necessarily that and perhaps it works in the medical research and medical practice context, because you have these scientists who go in day and day out and treat them like no differently than they would any other experimental non-human subject, right? And this is what happens with, I would say, J. Marion Sims and some of what happens there, right? It's I think that they may well have hated Black people and had this traditional racism that we know, and that's certainly the case. But also they didn't see them as human. They don't see them as human, right? And so that's how you can treat them in a particular way, right? This and I try to borrow from some of what's going on with the police violence context, right? And how it is that dehumanization happens, and how it, for me, the key issue is just apathy to violence to the Black body, right? And that comes out in not only subjecting Black people, just having no thought about subjecting a Black woman to multiple surgeries, right? There's no reason why somebody should have 5 C-sections. Those are 5 major surgeries over your lifetime. But at that point, your body, right? I mean, that's just right. I think that's just in the United States because of so much medical violence and white supremacy. And so I think that dehumanization allows us to think about some of the ways in which even just the taken for granted ways in which how who gets studied, which bodies are used for studies. Recently there's a study that came out with John Hopkins, this colonoscopy study, and 75% of the subjects were Black. And there's a lot of conversation about, usually studies are supposed to be random, and there's no random distribution in any study that should result in such a disproportionate number of Black people, right? And then in medical schools and medical education, who gets subjected to these procedures disproportionately? And that these are still some of the practices that are happening. And I don't, so for me, it's this dehumanization lens is something that I'm still working with and seeing how it's useful. I'd like to connect some of the similarities in police violence, that type of discourse, to what's going on with medical violence. because I think that they're very similar. And so I know I interrupted you when I mentioned the being a humble Black woman.
Oh yeah, no, I'm
Say
saying that you don't have to do that
something.
here.
Okay, that's true.
You don't have to be that here.
I know, right?
So,
So
hmm?
yeah, so I'm still thinking about it and what it offers, and I think that it could definitely be a powerful way of conceptualizing what's going on. And so, what does it mean? How do you institutionalize, right, humanity, right?
Hmm.
Right, thinking of somebody as, right, worthy of, right, the same, right, moral treatment and right,
Yeah,
empathy, right? I think you're more likely to have empathy, right, and compassion if you see somebody as, right, not just somebody to get a surgery under your belt if you're a resident, in a residency program, but also, right, somebody who is, worthy of, right, just all the basic things that we give to other patients: informed consent, respect, bodily integrity, autonomy, and so forth. So
yeah. I think that the distinction that you make is really important because we are kind of guided into choosing from the words that we're given to describe what's happening. We're choosing from a really sanitized, defined down kind of notion of racism in the media today, because we're not, in this case, we're not talking about symbolic forms of racism or um, someone calling a person a name or a racial epithet. We're talking about destroying somebody's life
yeah.
and or severely limiting someone's life chances. And historically, in order to do that,
Yeah.
the pretext or the thing that's enabled white supremacists to do that is dehumanization. So I think that was very important. And you mentioned institutionalization because, and that comes to mind because you you open up just going back to how you open up the article that you wrote with the experience of Serena Williams, who became her own advocate while she was a patient at the same time, and having to be clear of mind at the same time, and be an advocate and both a patient. And yes, it's important for Black women to have that sort of agency, but what can be done so that they don't have to do that? To what kind of practices, what kind of institutional practices do you recommend so that people don't have to, Black women don't have to be as Serena Williams had to be in that moment,
fighting while they
right?
give birth for their lives, essentially.
Right.
I think that's what my article doesn't do it, right? So when I do get my book out, right, it will talk about solutions, policy
Oh,
solutions.
great.
So that's a good question. I think, I'm gonna just talk about some, right, kind of obvious um, solutions which have been a part of the recent conversations, right? So I think every Black woman should have a doula who is a birth worker who, can support them and advocate for them. And not just one doula. They may need a couple of doulas, right? And I think just having more, right, support and voices while they give birth, and that's usually traditionally performed by the family. Um, but often people get pushed out of the room while birth is happening, and so you don't have necessarily witnesses to what happened. But I definitely support state subsidization of doulas, and that some of that has been gaining traction in some states. And so I think that certainly, what a doula can do is help the right, the mother also, remember what their birth plan was going in, because a lot of women, right, have a birth plan. This is what they want, and then ultimately that gets thrown out once it starts. But also a doula can be a witness to what happened, right? And so they can see some of the violence that's happening, and they have served as an important witness. And then, finally, just having, the moral support there is encouraging to the mother. I think definitely there has to be more institutional changes as well in terms of how medicine gets practiced and how it's taught. I think that, the fact that a lot of medical actors, residents, doctors still think that Black people feel pain differently, or their skin is there's something physiologically distinct about their bodies, right? Indicates that there has to be more work done in medical education to undo some of this problematic beliefs about Black bodies, because that affects, who gets treatment for pain, whose pain complaints are recognized and honored. And I do, I think that, before, so I'm going to be a little bit old school, before modern obstetrics, we used to have midwives in Black communities in the United States. And, those got pushed out of, the Black community, and, were replaced by what we have today, which is this, obstetrics that's really, what it's, all of the issues that I've described. So, so I do push for more midwifery centered support or birthing support. Unfortunately, in the United States, midwifery tends to be dominated by white patients, white women who can afford those. But I'll say this for myself, I was given birth by a midwife. And so when you started asking me in the beginning, how does my background as a Jamaican influence some of this, When I think about my own birth story, I was given birth in rural Jamaica in the 80s by the same midwife who delivered my mother and delivered generations of Black women. And this was a Black midwife who was really skilled and knew how to send women to the doctor if she couldn't do what she needed to do. But also, the way that I was given birth, it's not the way that a lot of Black women are given birth in the United States. And so just, I think that every baby, Black baby, should be welcomed into the world in a very nurturing, affirming, loving, supporting environment, which is not what we're having in most hospitals today. And so I think that, I do contrast that experience, that birth story that I do have, being privileged to grow up in that environment in a Black country where, Black babies, when they're born, it's a lot of love that's waiting for them outside within the society. And, the environment is very different than here in a different medical system. In thinking about some of these policy issues, I do think that I do push for more midwifery centered practice, because if you have a skilled midwife, that the birth outcomes are as safe, but also institutionally reforming medicine itself. Those, that must be tackled. And so it's not one or the other, so it's a variety of things that I think need to be addressed in the United States.
You use critical race theory as part of your approach and intersectionality. There is currently, this is not necessarily related to your article, but there's currently an attack on critical race theory.
Right.
What is your take on this current attack on critical race theory?
I think, so I think, unfortunately, a lot of people attacking critical race theory have no idea what critical race theory is, have never read anything by a critical race scholar, and have no intention of being informed about it. And it has, you know, some of it is, I don't know how meaningful some of it was in terms of the prior administration and the policies in terms of, right, banning critical race theory. I think, or bias training, in like federal employees or among federal employees. And so, right, that hasn't stopped me from doing my job. I teach it with glee in my classroom, and it's essential for any student of law to know about how the law intersects with race and how the law has been a key architect of race. So we're talking, right, one key principle of critical race theory is that the law has been a significant actor in producing or creating race, right? And if we talk about how these laws of hyper descent emerged in America, right, and their sole purpose was at one point to increase who would be considered as Black, right? And so you have the one drop rule, right? No matter what your racial background is, no matter what you look like phenotypically, if you can trace a minutia of, quote unquote, Black blood, then you're Black. And that has everything to do with making sure that we have, right, a broad swath around, right, just feeding the institution of slavery, and also this idea of whiteness constructing this pure white race that's not degraded by other races or by others. And so, right, law has everything to do with how we understand race as being this biological thing, right, in our bodies. And that's a key, right, idea of critical race theory. The law also is a key actor in, right, institutionalizing racial subordination, right? So it not only constructs race, right, it institutionalizes it and forces racial domination, right? And so I think that, right, more than ever, right, we need to have meaningful conversations about it. All of this fight against it in the high school, right, context, I don't really necessarily pay as much attention to it because I didn't learn critical race theory in high school. I don't think they teach it necessarily in high school. And so I think, some of it is just, right, it's a non-issue in the sense of, well, it's an issue in the sense of it might be stifling high school teachers in doing what they need to do. But as far as the legal, the law school context, or the in my field or profession, I don't like, right, I'm gonna do what I need to do. I don't feel right that that what's going on politically is affecting my ability to do my job, but I know that it's there. And I tell my students, right, regardless of what your political background is, you need to have fluency in everything that's happening in conversation. So if you are going to believe that critical race theory is bad for you, it's whatever, it's distorting American history, first know what it is. Right? And I can give you the tools for that, right? This is critical race theory 101. And then you can decide whether or not it's distorting American history and painting, right, this bad picture of what America is. And so, that's what I have to say about, what's going on.
Yeah, it seems like it's very much political framing, and it's being used for political purposes, which very rarely has anything to do with the true essence of a thing. So it seems typical in that sense, but the consequences, I think, can be quite problematic. Is there anything that that we didn't cover that you wanted to speak to without humility even at all?
Well, I'm a newly minted PhD, so but
Okay.
I'll learn
Oh, I understand.
to
You have to be
drop some of
careful.
that humility. No, it's been great talking with you. Thank you so much for the work that you're doing in amplifying these issues for the community. It's very important. I really appreciate, you taking the time to grapple with my work, and it's been a pleasure being here and speaking with you. So I have nothing else to add.
Okay, well, thank you. And I think that again, you have a unique background, a unique I mean, as we learned today through the discussion, that it's informed by your Jamaican cultural heritage, as well as your, I mean, law, union workers, and sociology, African American studies, all of these different things that are not all over the place. I don't think it seems that you have marshaled all of them to develop a unique approach to looking at Black women at the intersection of law and medicine. And I hope that your analysis reaches the ears of uh, Black communities all over, and that you can ultimately have a big impact on Black women and practices that they can employ to protect their agency and health in a hostile medical climate.
Thank you.
So thank you.
There's yeah. There's one thing that I would like to add, and this is more personal. And so I spoke about the pandemic in the abstract as an academic, but I'm one of those people who got COVID earlier in the spring of last year, and I also happen to be one of those who had to deal with the long-term side effects from it, and a lot of that experience has just reinforced the need for some of the work that I do. And so, I know that a lot of people are still dealing with it. I've recently joined some of these, what we call long COVID support groups and women of color. Yeah. And there's some recent advocacy around that, making sure that the medical needs are being met. And, there's a lot, it's an uphill battle. And so I just, I want to just, I guess, give a, acknowledgement of some of what's going on with some of the women of color that I've connected with recently, the Black women who are advocating for more medical attention to these issues. And right, I care about not only Black women's ability to reproduce and have healthy reproductive lives, but to also be able to have their medical needs met and just have basic healthcare needs met. And that's right now, there's a lot of challenges there, and that's another issue altogether. But that's the only thing that I'd like to add. And so fortunately, I'm doing better, but it's taken a year-long healing, so to speak. And some people are still not fully recovered. And there's some traction on, trying to deal with it, but it is a difficult thing. So just like to draw attention to that.
Yes, I had read a little bit about long COVID and the ongoing symptoms. So I appreciate you adding that.
Sure.
And maybe it's also something that there's a book forthcoming. Did I hear that correctly?
You certainly did. After the obstetrics violence book.
Okay. Okay, there's a couple of book projects.
There's a couple of book projects. I've been, it's a slow writing process, especially during the pandemic, but definitely I want to write about some of the issues that are happening now in terms of, the difficulties that Black women are having getting the support that they need, that comes from just the pandemic, but also it intersects with what's been going on pre-pandemic. So I'll definitely write about that.
So I hope that you can share with me your social media handles. I want to ask people if they to reach out to you for questions, if they have any, to draw on your expertise.
I need to get my Twitter page set up. So I'm kind of like
okay.
Old
no
school.
problem.
But I do, I have a LinkedIn profile, so that's
okay. LinkedIn. Yeah, absolutely. That
I can reach there, and anyone who wants to email me, my profile on my website, my faculty website is up there, so people can reach me through my email there.
Yeah, and but that faculty website is very helpful if you all want, because there's 2 articles that are available there that you all can, that anyone who's watching can look at. They are Medical Violence, Obstetric Racism, and the Limits of Informed Consent for Black Women. You can click on the link, anyone who's interested, and read that. You can also read Racial Inclusivity in COVID-19 Vaccine Trials, the Petrie-Flom Center Bill of Health blog. So you can click on and read those articles. Very important voice in terms of law and medicine, particularly for Black women, for all of us, and on the topic of Black women at the intersection of race and law. So I wish you much success in the future.
Thank you.
And for everyone who is watching this, stay tuned for our next episode of Afrometrics Research-Based News. Thank you very much.
Thank you. Have a good one.
You too.